Today we are going to discuss about the pharmacology of local anesthetic agents and the vasoconstrictors. As all of you know, local anesthetic agents are one of the very important pharmacological agents which aid any surgeons for performing any minor surgeries. Looking at the history, few of the materials which were used in the earlier days, we'll get to know that cocaine was the first anesthetic to be used in the surgeries. That is, in 1860, it was used for anesthetizing the structures. And in 1884, Sigmund Freud and Carl Kohler was the one to use it in the surgical field. And Horace Wells was the one who demonstrated the surgical planes of anesthesia. And lignocaine, the most commonly used local anesthetic agents these days, is was first used in Sweden in 1984. Sorry, 1948. Anesthesia or a local anesthesia can be defined as a reversible loss of sensation in the circumscribed area of the body caused by a depression of excitation in the nerve endings or an inhibition of the conduction process in peripheral nerves. There is a transient loss of sensation without loss of consciousness. Local anesthetic agents consist of the main ingredient, or that is a local anesthetic agent, the lignocaine, vasoconstrictor, the adrenaline in the concentration of 1 is to 1 lakh or 1 is to 2 lakhs, a reducing agent which is sodium metabisulfite, which acts as an antioxidant for vasoconstrictor, and a preservative methylparaben or cupryl hydroxycuprinotoxin, which is a bacteriostatic, and a fungicide, which is a thymol, and a vehicle, which is distilled water, along with for isotonicity, sodium chloride is being added. Local anesthetic agents have a basic structure of aromatic ring and an ammonia group, which is interconnected by an intermediate chain, which is either a amide link or a ester link, based on which there are two main categories, that is the ester anesthetic agents and the amide anesthetic agents. An ester group consists of a benzoic acid esters and the para-aminobenzoic acid esters, and amide group has a lignocaine, bupropion, articaine, or etidocaine, and quinolones are the ones which are very rarely used. Based on the duration of the action, they can be divided into ultra short acting, which is less than 30 minutes, and short acting, which is between 45 to 75 minutes. Lignocaine and prelocaine, which acts for 30 to 150 minutes. Bupropion, which is a long acting, which acts for more than 180 minutes. Based on the biological site and mode of action, they can be classified into class A, B, C, and D. A is the one wherein the receptor site is present on the external surface of the nerve membrane, the example being biotoxin. Class B are the receptor site on the internal surface of the nerve membrane, that is lignocaine. Class C is the receptor independent mechanism, which is benzocaine, and class D are the combination of a receptor and receptor independent mechanism, like in case of prelocaine. So when we see this diagram, we'll come to know class A are the one which act on the external surface of the receptor, and B are the ones which act on the internal receptor, C are the ones which are intermediate, and D are the ones which act in combination with both. Based on the mode of application, they can be divided as topical and injectable. Topical are the one which act on application on the topical, and injectable are most commonly used by various methods or various techniques. How it works is local anesthetic blocks the nerve conduction by decreasing the entry of a sodium channel during the upstroke of action potential. Thereby, it blocks the nerve membrane conduction and blocks the conduction of the nociceptive impulses. Ideal properties of local anesthetic agents are its action should be reversible, it should be non toxic or non irritant to the tissues wherein we are injecting, should not cause any permanent alteration in the nerve structure. Time of onset should be short, and duration of action should be desirable enough to carry out the planned procedure, and the solution should be readily undergo biotransformation within the body. It should be either sterile or capable of being sterilized by heat without deterioration. Common properties of injectable anesthetics are they all are synthetic and contain amino group. Action of all the drugs are reversible. All affect the nerve conduction membrane in a similar manner, and all form a salt with a strong acid. And the salts are soluble in water. Anesthetic salts are acidic in reaction and relatively stable. Alkali increases the concentration of anionized free base, and anionized free base is soluble in the lipids. They all are either hydrolyzed by the plasma choline esterases or undergo biotransformation within the liver. All are compatible with epinephrine or the allied drugs and incompatible with the metal salts of mercury or silver. All are capable of producing the toxic systemic side effects when sufficiently high concentration of plasma is reached. How the local anesthetic dissociates is whenever a local anesthetic is injected into the tissue, it dissociates into the anion and hydrogen ion, and this unionized the local anesthetic agent passes through the lipid biomembrane, and when it reaches the interior or the axoplasm, it again combines with the hydrogen ion to form the cation, and then it works on the internal surface of the sodium channel. What are the factors which determine the effectiveness of a local anesthetic agents are its concentration, solubility, pH of the solution, protein binding rate. Concentration: higher the concentration of anesthetic solution, steeper is the rate of concentration gradient attained, and more rapidly is the drug penetrating the nerve cell membrane, and the conduction blockade happens quickly. The greater the solubility of anesthetic in both the aqueous and the lipid material, the less will be the delay in the effect of the tissues and the tissue fluids, and more rapid is the onset of anesthesia. pH of the solution pH of the solution, the tissue conditions which favor the anesthetics to cross the tissue, that is the bilipid phospholipid membrane, is whenever there is pH of the tissue is acidic in nature, it prevents its dissociation from the hydrogen ion, and the cationic form of the local anesthesia cannot readily pass through. That's why when the acidic conditions like inflammation or the infection are present, the local anesthetic effect will be lesser, as the anion is not freely passing through the lipid bilayer. Protein binding rate, that is, a rapid protein binding rate, produces a quick onset of anesthesia and a rapid separation of the bond protein. Thus, the time taken for the anesthesia to wear off and for a normal sensation to return. So, the protein binding, higher the protein binding, quicker is the action. How do we calculate the dosages? Percentage of the solution, gram of the solute, that is a drug dissolved in 100 ml of solvent. Example: 3% of mepivacaine solution contains 3 grams of mepivacaine dissolved in each 100 ml of solvent. That is, 3% of mepivacaine is equal to 10 milligrams per ml of the solution. It contains the 2 ml cartridge contains 30 into 2, that is 60 milligram of mepivacaine in single cartridge. Likewise, 2% lignocaine contains 20 milligram per ml, therefore 40 milligram per cartridge of local anesthetic agent. So, coming to the maximum dose for the local anesthetic agent without causing adverse reaction or the overdose reactions is lignocaine, 2% lignocaine, that is maximum concentration, maximum dose advisable is around 7 milligram per kg body weight. And bupivacaine is again 6.6, and the maximum is it is about 500 mg, the total. So this drug, whatever we inject within the tissue, has to undergo the biodegradation and has to be disposed out of the body. Otherwise, it will cause toxicity reaction. So it undergoes biotransformation within the plasma. That is, the ester group undergoes dissociation within the plasma with the help of hydrolysis, as well as the amide group undergoes hydrolysis and hydrolysis and uh, conjugation in the liver, and from there these are excreted through the kidney. So, the local anesthetic agent, when it is deposited in the tissue near the axons, it is absorbed by the non-specific tissues absorption. It enters into the bloodstreams. From the bloodstream, it can get metabolized through the plasma cholinesterase or in the liver by hepatic metabolism, and it can be excreted. And the one which reaches the bloodstream before it is getting metabolized, it can get distributed to the important structures like brain, heart, and the systemic tissues. So within the brain, it can cause systemic toxicity, cardiovascular toxicity, and systemic tissues. Systemic toxicity depends upon the plasma or the serum concentration, and when the serum concentration is between 0 to 5 microgram per deciliter, then it has got antiarrhythmic and anticonvulsant effect. But when the concentration goes on increasing, the lower concentration, first clinically it suppresses the cardiac dysarrhythmias and seizures, but the higher concentration induces the seizure activity and the muscle twitching and coma, and finally the respiratory arrest and the CVS depression. So, avoiding systemic toxicity by following certain ways or certain techniques is very, very important to prevent the toxicity and to prevent the adverse effect on the CVS as well as CNS. Moving on to the vasoconstrictors, which are one of the component of a local anesthetic solution. It is added to the local anesthetic solution so that the toxicity levels of the lidocaine are reduced, because local anesthetics by nature are vasodilators. So when the vasodilation happens, they are rapidly absorbed into systemic circulation and they have a more tendency for having a toxicity. That is one. Second thing is, when they are rapidly removed from the area of injection, they are not available for the local effect. That is, the duration for which it has to act will not act. So as to increase the duration of action of a local anesthetic agent, also the vasoconstrictors are helpful. So the vasoconstrictors cause the vasoconstriction, and thereby they keep the solution localized in a local area and increase the depth and prolongs the duration of anesthesia, and they reduce the toxicity. So they decrease the blood flow, one. Next is lowers the anesthetic blood levels, decrease the risk of toxicity, increase the duration of action, and decrease the bleeding. So the vasoconstrictors are classified into two categories, mainly the catecholamines and the non-catecholamines. Catecholamines being the epinephrine and norepinephrine, non-catecholamines being the ephedrine and amphetamine. So catecholamines are the ones which are most commonly used. They exhibit a considerable cardiac stimulation because of the beta 1 agonistic effect or action on, in addition to its desired vasoconstrictive activity. So the beta 1 activity is on the cardiac muscles. So the concentration of 1 is to 1 lakh epinephrine contains 1 gram of epinephrine dissolved in 1 lakh ml of solvent. So that makes it up to uh, So the concentration of a lignocaine, epinephrine, has to be kept to the bare minimum possible to prevent the side effects of the epinephrine. So the maximum dose for the dental appointment in the normal healthy individuals is zero point 0.2 milligram per appointment, and patients with having cardiovascular ailments or impairment has to be restricted to zero point zero 0.04 milligram per appointment, whereas norepinephrine in a healthy patient is zero point 0.3 milligram per appointment, and a cardiovascular disease patient is 0.14 milligram per appointment. Levonorepinephrine is another vasoconstrictor which is combined along with a 2% mepivacaine solution in the United States. It is closely resembles norepinephrine rather than the epinephrine and lacks the activity at the beta 2 receptors. Epinephrine increases the heart rate and the systolic pressure but lowers the diastolic pressure. When we are treating the patient with a cardiovascular disease, it is safer to use levonorepinephrine rather than using the epinephrine. We have a eutectic mixture of a lignocaine along with a prilocaine, that is 2.5% of lignocaine and a prilocaine, which is a mixture of 1 ml of 2% lignocaine and 1 ml of sorry which is 1 ml of lignocaine and 1 ml of prilocaine in the concentration of 2.5 percentage, that is emla cream, which acts as a topical agent. It acts on it works as a surface anesthesia even in the intact skin. So, whenever the local anesthetic agent, when it is used in a higher concentration, or there is an inadvertent injection intravenously without aspirating it, then it will have a higher concentration into the plasma levels, which can have a toxic effects, and it can show a toxic effect on the cerebrovascular system or the cardiovascular system. So as to reverse this, phentylamine mesylate is the one which is being used in a concentration of zero point 0.4 milligrams in 1.7 ml cartridge. This helps in reversal of anesthesia after the procedure, especially in the children, prevents the lip bite and unnecessary long time of exposure to anesthesia, as well as decreases the toxicity of anesthesia. So whenever there is a systemic toxicity, then a reversal of phentylamine is necessary, and it has to be given in the concentration of zero point 0.4 milligrams, so that there is a quick reversal of a lignocaine effect onto the CVS or the CNS, so that they do not have a prolonged adverse effect on the CNS or the CVS, and the patient's revival is possible. Along with that, maintaining the patient's uh, condition or metabolic condition stable, we'll have to keep monitoring the patient till the reversal of the drugs takes place.